about patient-centered care. And I want to talk about the art of the patient-centered consultation, because for me personally, I have found some of my greatest satisfaction out of medicine is when I have a patient-centered consultation. And as soon as I go more and more doctor-centered, that's when I get burnt out and exhausted. And I find that when I do provide patient-centered care, which is not always possible, my patients are always appreciative. I'll get at least 80% of my patients will be saying, thank you, and we want you to be my doctor, and oh, I'm so happy that I was with you today. And so I get a lot of positive feedback when I do patient-centered care. Now, the challenge is we live in a society in terms of medicine where we only get trained actually in doctor-centered care. And although we know we all do the biopsychosocial approach and we're all family physicians, actually what happens in practice, and it's partly the way our healthcare systems are set up worldwide, is we're very much in a doctor-centered mode. And actually mostly what you get more in your universities is doctor-centered care. And that's why you end up going into your consultations when you start seeing patients and you just feel exhausted. You're like a nurse, we're looking after the ward, and every day just seems like a drag. And the reason for this is, and we'll look a little bit at what's the difference between these two when I say doctor versus patient-centered care. So doctor-centered care means that I shall diagnose the illness, the risks of the illness through examination, inquiry, and investigation. I realize I should call this clinician-centered care. Sorry, old slide. So this is valid for anybody who works in the health professions. And there's this idea is that I'm here to now make this assessment of this patient, and then I'm going to come up with a suitable plan or treatment intervention, or whether it's a nursing intervention that needs to be happening. And I am there to now restore the patient to health or help them with their illness or prevent further complications or prevent disease. And we have stacks of guidelines that tells us all the stuff we're supposed to do, right? So with diabetes, we've got all these targets. So if you've got a patient with diabetes and dyslipidemia and sore back and you're unable to walk properly, et cetera, and you're looking after them in whatever clinician setting you are at, you will have a whole lot of stuff that you're supposed to do. So as a doctor, you're supposed to treat a target. Rehab, you're supposed to do this full assessment on your patient. Dietitian, you're supposed to be able to give all this whole full menu plan. So we have all these tick boxes that's supposed to happen with each and every single patient. And actually, if you do all of that in a consultation, most of your consultation is focusing around getting all this stuff done. And there's very little time to actually look at what the patient needs. So patient-centered care means that I'm actually going to identify my patient's agenda. And the patient doesn't even always know what their agenda is, because sometimes it's unconscious. So you're going to try and elicit and figure out what they need. Then you're going to use all these great skills that you have to now assist them to come up with a treatment plan that's going to help them reach their goals. And a really good physician will then use some of these doctor-centered stuff to slip them into the patient's goals and create a nice comprehensive package. In reality, what this looks like in a consultation is that patient-centered care, you're not going to bring all of your priorities into one consultation. You're going to figure out what your patient needs, and then over time, which is what we love doing in family medicine, you might bring one or two doctor-centered issues to each and every consultation, and I actually keep track of that over time. So bizarrely enough, proper patient-centered care is very efficient. My appointments are much shorter than when I do doctor-centered care, and I get stuff done not in a single appointment, but over time, and actually much more of that gets implemented than if I throw my patient with a million suggestions. So how do we do that? How do we create an atmosphere or a style that creates a patient-centered consultation? And I'm going to give you just a few top tips. The first easy thing to do is rearrange your room. So there's something called a closed and an open room arrangement. I find most students don't seem to know about this, but there's a way that you can create a feeling that I am the great doctor and you are the little patient. And there's a way of creating an atmosphere of we are working on something together. Okay, so room arrangement is very obvious. So this is a nice closed consultation, which we don't want. So you can see there's a table, there's a chair behind the table. There's also terrible for infection control if air blows from the patient over the doctor out the window. And similarly here, you can see there's a table, there's even a nice big computer.
Operational manager, specialty. So
first,
you can't, she's way far.
That's a very a doctor saying the doctor's got a barrier between themselves and the patient. If we look at this pictures on the right for the open presentation, the open consultation room. So just if you get a bit disorientated, so there's the table, there's the doctor's chair, there's the patient's chair, there's the window. So also the air blows nicely from the doctor past the patient out the window, much better for infection control, but there's the possibility to have an open space between you and the patient. And there's actually, sorry, oops. There we go, a nice picture of, and quite often we have seen rooms like that. And wherever I go, I tend to rearrange consulting rooms, and you just create a different style right from the moment. And then there's 3 questions I want to teach you, or 3 tips rather, that you can use to just help start identifying early on in your consultation what your patient's agenda is. And no, it's not all about RuReSA. RuReSA is the end result. I'll tell you about RuReSA, those of you who don't know what that is. The first thing is being able to create a nice open question. So I like to make my patients feel welcome from the moment they walk into my consulting room. In the old days, before COVID, I used to shake each patient's hand. That really surprises them. But now I invite them in, wamkelekile, preferably in whatever language they're speaking. I greet them, I introduce myself, and I create a picture that I'm very happy to see you and I'm here to help you. And you can create a nice open kickstart question that's basically open on what they want to. And then this is the important bit. Once you've asked your question, your patient is comfortable, there's something called the golden minute. And this has been very well researched, and where they've looked at how long does it take doctors to interrupt their patient. And on average, it's 18 seconds from when the patient starts talking. And there was a paper in internal medicine, which was 11 seconds before a doctor interrupts. I'll give you a good example. So you sit down, you say to the patient, how can I help? And the patient says, well, I've been coughing. And then you go, oh, when did that start? And then you start asking all the questions. And are you sweating? And have you lost weight? And you've actually interrupted your patient after 5 seconds. So it takes a little bit of discipline because it feels like it's a very long time, but 60 seconds is not much time out of your total consultation. And being able to bite your tongue and wait for the patient to talk. And sometimes they start and then you wait and you just let them talk until they've literally talked themselves dry. And it's amazing the stuff that comes out during that 60 seconds. Now they've talked themselves dry, and then what do you ask next? This is called the OR question, and it stands for, and what else? And being able to ask, and what else, until you have extracted everything that's been going in your patient's brain while they were sitting in the waiting room. And then you start getting a really good idea, what is it that my patient thought was going to happen today? And what we're listening for is the reason why they finally decided to come today for their problem. What are their ideas about what they think is going on? What are they really worried about as they think is going to happen? And what do they think that you're actually going to do that day? And that's the classic RICE of the RICE that we use to identify our patient's agenda. If you do this, it only takes 3 or 4 minutes. It doesn't take a lot of time. And if you have a patient who needs to say a lot, then you actually do need to hear all the stuff they need to say, or it's going to come back later. And all of this gives you the possibility of building a consultation around your patient's agenda. So that's a very brief little inspiration around patient-centered care. And I'm going to encourage you to just go and try that with your consultations from now on. Don't matter if you're a nurse in the morning in the ward round, clinical associate or doctor in a consultation, or a rehab person doing an assessment of a patient, go for the golden minute and the OR question and what else, and see what happens. So now we're going to move on to a related but slightly different issue, which is around how we work with our colleagues and team members. And I think especially when you are in a rural setting, your team's usually quite small. And you live and work with these people. You literally live in the house next door to them. You see them in the day, you see them in the evening. They are your whole world, that bunch of people that you work with. And if you don't get on with those people, and if those relationships are difficult, then your life in a rural hospital is going to be horrible. If you are in a nice big urban setting, well, at least when you leave home, you've got your own friends and you've got your own family and you can go to the movies and do other stuff. But in a rural setting, your team is extremely important. But there's other reasons why it's very important to get on with your team. And this has to do in terms of care for our patients. And for this, I'm going to tell you a fun story. Great. So this is completely, we're going to take this from the aviation history. And some of you, well, this is way before your times. I'm going to go back to Tenerife, March 1977. And our story is about Captain Jacob van Zanten, who is a top pilot from KLM Royal Dutch Airlines. He's their director of safety. He's the face of their advertising campaign. He's had 30 years of experience. And I want you to imagine, when you think of Captain van Zanten, I want you to imagine like that senior surgeon in the theater at when you've done surgery, if you've done surgery rotations, or if you're a nurse, I want you to imagine the doctor that comes on ward rounds in your ward, or if you are in rehab, the orthopedic surgeon that you have had to work with. These are senior people, very experienced, and who's partly in charge of the team or the plane in this case. So on this particular day, there was a bomb threat somewhere else, and all the flights had been deflected to Tenerife, which was a small airport that only had one runway. And it's been taking ages to get on the runway, and everybody's running late, and Captain van Zanten is quite stressed. So he's in dragon mode, remember? And his brain is not working 100%. And there's a very heavy fog, so you can hardly see anything. And finally, he is on the runway, and now they're busy getting all their flight clearances, but the poor guy in the flight tower is completely overwhelmed, and there's lots of communication challenges also in terms of language. So during this time, there are at least three instances that they recognized later, where the co-pilot twice raised some concern and once the flight engineer. But every single time, Captain van Zanten, and you know those senior colleague, you watch a senior colleague and you think, oh, I wonder if that's right. And then when you bring it up, it's like, oh, don't be silly or don't be ridiculous, and they both quickly backed down and thought, no, the captain should know what he's doing, right? So Captain van Zanten is finally on the runway. He can't see very much, starts accelerating 40 knots, 80 knots. And at 112 knots, finally, some of this fog clears off the runway. And there, 1,500 foot away, is a Pan Am 747, massive plane, sideways on the runway, stuck in a turn they were struggling to navigate. That looked a bit like that. And what the captain then did is he realized there's no way he was going to have time to stop. Boeings don't stop that easily. It was not fast enough to actually take off. And he thought, well, maybe I can frog leap. Maybe I can just jump over this plane. So he pulls back on the whatever you call that. And as he goes over, remember his landing gear would still be out. The landing gear takes out the whole middle of that Pan Am, and he crashes down on the other side in a big ball of fire. 583 people die in less than like 45 seconds. 248 from them, where it was everybody on the KLM flight died, as well as 335 on the Pan Am flight, and literally only 61 people survived. And this is the worst aviation accident in history. So it's interesting, why am I telling you this story? Because what was interesting is the way the KLM reacted to this. Because the normal thing, this is what we do as doctors, right? If you had a disaster like that in theater, then we nail the clinician to the wall. But KLM looked at that and went, hold on, this is a highly experienced pilot. He's a really, really good man. And sure, he made a mistake, but if he makes a mistake, anybody can make a mistake. And so they identified an issue of what they called organizational culture. And partly what they organized, and see if this sounds familiar for our own organizational cultures, the captain is always right, senior doctor is always right. And the culture that discounts the value of the crew. So we're not interested in the opinion of the pharmacy assistant or the student nurse or the clinical associate, because there's this hierarchy of assumed knowledge. So this had an effect on the medical profession, and you'll see there's a book there, How Hospitals Should Fly, which is where I got this whole story from, specifically written by a doctor. And in 1999, it's not 20 years later, the Institute of Medicine actually brought out this very landmark report called To Err is Human, and identified the fact that medical mistakes are human mistakes committed within a human system that has been inadequately designed to catch and neutralize those mistakes. So the assumption is now humans always make mistakes. You can't get away from that. Doesn't matter how trained they are, how experienced they are, or how determined they are not to make a mistake. We all have dragon days. We all have days we're going to, and this is something that's quite hard for you as a young student or doctor to face. Oh my goodness, I am going to be making mistakes, high stake mistakes for the rest of my life. So I wanted to give this little example. forgive me if I deflect for 1 minute, to cricket, because in cricket, you get a batting score, right, in terms of how many balls you've successfully hit with your bat. Well, imagine if doctors were given a batting score and you were given a number, a percentage of how many times you get your diagnosis, your assessment, or your treatment plan correct. So how many times do you make the correct decision for your patient? And the question is, what do you think your patients think your batting score is? Or if you were to go to an oncologist or you were to go to a doctor yourself, what are you expecting the batting score of that clinician to be? And I know this is very uninteractive because we are on Zoom, but I've done lots of these sessions, and most doctors will go, well, gosh, I think most patients will expect well over 90%, if not 100%. We expect the doctor to always be right. And as a doctor, we've internalized this expectation. We've internalized this expectation that we can't be making mistakes. I can't be making the wrong diagnosis or giving them the wrong treatment or coming up with the wrong plan for my particular patient. I'm supposed to always be right. And unfortunately, especially with dragon mode there's lots of ways to make mistakes. Sometimes we just read something wrong or we misunderstand something. Sometimes we make assumptions. We think we're going to give saline, but meanwhile we have a vial of potassium in our hand. Sometimes miscommunication, you read the handwriting wrong or you miscommunicate something over a phone. And important, these mistakes obviously get worse when we're under pressure. So stress, remember, makes you stupid. It's usually not one root cause or one major cause. There's usually a whole lot of things all going wrong at one after the other. And we cannot prevent clinicians from making mistakes. There's no ways. So the idea is more is we can prevent a mistake from becoming a disaster. And what the aviation injury did is they decided that they were going to start these interactive teams where there must be mutual caring and support. Everybody is equal across the board, and they call it barrierless communication. And what's interesting with this is when they implemented this, within 10, 15 years, there was no aviation accidents in that particular 1 year, where in hospitals in America, there was still the equivalent of 1,400 full Boeing planes of medical mistakes that led to major consequences. So we as a medical profession, although we've realized this, the aviation industry actually managed to address this, but we haven't managed to address this in the medical profession. And we are facing challenges. So you might find that you go into a culture at a hospital where there's still a culture of when ideas or suggestions or opinions come up, it's considered as unacceptable to challenge authority. And it's a culture that discourages people from speaking up. And what you want to make sure to do is not to perpetuate that culture. You can't always influence the clinical manager at the hospital where you work. But for example, where I work, I have a very good relationship with my pharmacists. And sometimes one does do stupid things. So for example, I've worked in TB for years, and on certain TB treatment, you have to double the dose of dolutegravir. I had a very complicated patient with a whole lot of other stuff, and I forgot to double the dose of the dolutegravir, and my pharmacist came back to me. So every time our pharmacist picks up a mistake, I'm always extremely grateful. And even if they pick something up that wasn't a mistake, I'm always very grateful and say to him, thank you so much for coming to check that for me. And it's a problem if you are a team leader. And remember, as healthcare clinicians, you will be managing teams eventually. If your system is based on some of those dragon qualities we talked about earlier. So how did that now become practical? How do you create a great team? So if you are a young doctor, even if you're a ComServe officer, and now you've been told that you're running the medical ward or you're running the rehab section in your hospital, there's some places where they don't even have a qualified, a senior rehab person that might be overseeing you. How do you now build a team, even if you're there for a short period of time? And this is all to do about how we train our dragons. So we have this dragon master and we have this dragon. You cannot get away from your dragon. Your dragon is integrally part of your consciousness. So on your consciousness journey, we always have our dragons interacting with the world, checking out the world, screening the world. But we want to make sure that we are the ones that actually decide how and where that dragon is going to go. And in terms of relationships, what tends to happen, so imagine you are in a scenario where you come into like an MDT, for example, a multidisciplinary team meeting in your hospital. You are maybe one of the senior colleagues there, or maybe you're one of the new junior colleagues there. And you're sitting there and somebody in the room either criticizes you, tells you that you've done something wrong, or ignores or avoids you, doesn't, you try and speak up, but they don't even give you a chance, or they just dismiss anything you try and say, or they try and manipulate you. It's when you guys trying to do on-call rosters. Or you've got suggestions that you want to change. Everybody goes, oh, no, man, that will never work. We've tried that before. You have no idea what you're talking about. And what happens when you get approached, like, because you can notice, those are all dragon stuff, right? And what happens is that a dragon action will usually elicit an even greater dragon reaction. So you actually have an experience of your own dragons coming to the fore, and now you get dragon on dragon, and now you have those horrible conversations, the ones where you afterwards cry yourself to sleep. And this not only happens obviously in the workplace, this also happens in our relationships at home. So how do we counter that? How do we get in control of this dragon? It's such a powerful part of ourselves. And developmentally, actually, this is something that happens over a lifetime, this dragon training. So I'm going to use the word mind sight, which is sort of the skill set that you're developing, that is a skill set that belongs to this dragon master. And you want to imagine you've got this lovely dragon. It's a lovely dragon. We don't hate our dragons. We love our dragons. And it's beautiful and it's powerful and it's stupid. And what's interesting to note when you look neurodevelopmentally is that your limbic brain starts to myelinize and develop properly when you're about 2-3 years old. And then by 14 years old, you've got a fully developed survival system. All your endocrinology, all of that is nicely in place. Dragon is full and powerful. But the dragon master develops much slowly. So it eventually needs to learn to control that dragon, but it develops later than the dragon. So usually it kicks in by about 8-9. Your prefrontal process actually goes, your prefrontal cortex goes online. So you have access to those 4 qualities that I talked about. But there's an apprentice phase. So you can see here, I think that's his child, maybe it's his wife, on the dragon, learning how to control their own dragon. So between the ages of 12 and 23, whenever you are being empathic or reflective or planning, you are building neural networks and developing that dragon mastery of yourself. And ideally, when we talk about education and when you walk with teenagers, you need to be aware of how do we look after this fledgling dragon apprentice, master apprentice, who's now controlling this fully fledged dragon. And you'll see most of you, well, I don't know most, but quite a few of you are probably still under 23. So if you sometimes feel, oh my goodness, there's no ways I'm ever going to get on top of my dragon, it's fine. Your prefrontal cortex is still developing. It's still creating more neural networks. You're going to have more and more possibility to create power over your dragon. What is worrying though is we do see quite a lot of people as a society, we're still a little bit young. And we do see many adults who never quite get their dragon masters completely in, and they tend to live in that dragon mode. And we see that sometimes even in our lecturers, even in some of our senior doctors, that you are meeting people who are actually in dragon mode and you're not meeting this higher master. So there's another great book if you're really interested in this kind of neurophysiology and you're really interested in understanding on how to master it, written by Daniel Siegel. He's got a great one called Brainstorm as well, if you want to work with adolescents eventually. And Daniel Siegel, you remember I talked about that integration we want to get between our dragon and master. So it's not that you either got a dragon or either got a master. You either have dragon only or you have dragon being controlled by the master, and that we call this integration. So there's 3 exercises you want to think about in terms of controlling this dragon. The first thing you want to develop is what we're going to call dual awareness. And that's the easiest one to start practicing in the beginning. If you do nothing else but start with this, it's a very good start. And we're not going to do the exercise because I think this time of the night, you do not have enough higher functions to sit and do the exercise. But the exercise you would do if you want to observe or do this dual awareness exercise is to try and do one of those mindfulness exercises or meditations where you have to completely clear your brain of all thoughts. So you have to sit and think of nothing for 30 seconds, 1 minute, 5 minutes. Normally what we experience, I'm sure all of you have tried that at some point in some exercise or in prayer or in something like that, you'll notice that as you try and clear your thoughts, all kinds of thoughts come up. It's like amazing the amount of thoughts that gets produced by our brain all the time. And it can be in reaction to something you hear or something you think or something you see or something you feel. There's all these sensations that bubble up and it all becomes thoughts. What's interesting is not the thoughts. We have those, and that is a picture of the dragon brain creating all this endless stream of consciousness. But the ability that we can observe it and notice, oh, hold on, why am I thinking that now? I shouldn't be thinking that. Let me try and get rid of that thought. That part of you that can observe it and actually even suppress or stop that thought, that is your prefrontal cortex. So you can actually have an experience of having dual awareness. On the one hand, you have all these thoughts and ideas about the world. So there's a level of awareness there. And then you can be aware of being aware. And animals can't do that. So if you go through life and you're sitting in an MDT or you're sitting with a patient and the conversation's getting difficult and things are not working well, you can start to observe in yourself, hold on, where am I at in terms of dragon versus master mode? And where's my patient at in terms of dragon versus master mode? And just that knowledge already is very powerful. The next level up, and I do have a couple of slides on that, is being able to learn, and we often call that objectivity, which means switching into balcony view. So if you are observant and you notice, okay, hold on, this conversation is not going well. I'm clearly in dragon mode. How do I now switch to balcony mode? And I've got a slide on that. And then lastly, and we'll talk a little bit about that as well, I've got a slide on this as well, is the skill of being able to actually accept and love your dragon, as well as the dragons of other people. So the dragons make a lot of trouble. And the biggest problem with the dragons when they make trouble is if we get angry at them. It's like a puppy who messes on the floor and now you beat the poor puppy. We have to be sympathetic and gracious to our dragons. And quite often that's the most important skill you need to manage a dragon. More about that just now. So in terms of switching to balcony view, and this is just, this you all know from medical school, hopefully, or from any of the trainings that you are doing, that whenever we have a threat, we talked about that, your survival brain kicks in, you make adrenaline, you get your fight, flight response, and you start worrying. Remember, you've got all those negative thoughts. And the Buddha actually calls this the first arrow, whatever is making you feel unsafe. Your body actually changes. And then the second arrow is now you worry about the fact of what's going on, and that makes you feel more threatened. And the next thing you're in that cycle. So we explain this to our patients when they're having panic attacks as well. What you want to be able to do is to try and break this cycle. So the important thing to realize is that when you're trying to get to balcony view, you can't fight your physiology with thoughts. You can't tell yourself, no, I have to calm down. This is ridiculous. Why am I thinking like this? Oh my God, I'm in dragon's mode. You're still in the same little cycle. You have to try and reduce your level of adrenaline. If you can reduce your level of adrenaline, you will automatically gain access to the cleverer part of your brain. Oh, how clever is that? You do actually know this because we teach this to patients that when they're having a panic attack, they have to do active relaxation exercises and learning how to relax the body, be it through yoga or exercise or being able to do a mindfulness exercise, relaxing the body, physiologically relaxing all the muscles. Let your adrenal glands know that, oh, okay, the threat must be passed, and the adrenaline gets switched off. The other place to work on it, and that's when we work specifically with things like meditation, and please go and look up mindfulness if you've never heard of it. You can also use prayer or any meditative process that you have that's able to quiet the thoughts in terms of interrupting and thinking and usually focusing on something else. So I try not to reason with these thoughts. I'm just trying to quiet my mind so that I can try and break this cycle. So the important thing of this slide is more just to understand you have to physiologically address your adrenaline if you want to get to that higher level of thinking. And then there's the Dragon Master Superpower. So and this is particularly important if you're dealing with somebody now who is distressed. So I had a scenario during COVID where I had a nurse and we were just heard about COVID. We prepared this COVID ward. I was running the COVID ward at the TB hospital and my nurses were completely panicked. And we had the first nurses that called in with symptoms. So they'd not even been diagnosed yet. And I had a nurse who just completely melted. And I went into, and she wanted like one of those defumination angles and they wanted all to go home. And I, of course, she was in dragon mode and I went into dragon mode. And what I do is I preach. Wonder why? So yeah, I did a whole lecture on why this was not important, giving all the evidence, over analyzing and all of that. And at one stage she screamed at me and said, oh, you just for us to die. And I had a little wake up then and went, oh dear, okay, we're both definitely in a little dragon meltdown here. And so what do you do? What do you do in a scenario like that? I must say at that point, because I was very freaked out, I actually stood, I'll come back to you. And I walked out. That's sometimes all you can manage. But if you can get to balcony view, the superpower that you have when somebody else is having a meltdown is compassion. The reason why this works is that remember that when somebody's in dragon mode, they are not feeling safe, right? That's what triggers dragon mode. So if you're able to restore safety and make somebody just feel safe, you are able to some extent, not completely, but help them to move out of that mode. And by doing that, you've got to be nice to the dragon. You've got to be generous in assumptions. You can't then start attacking and criticizing and bringing your own dragon to the party. You've got to be able to accept that dragon, be gracious and be compassionate and figure out, how can I make this person feel safe right now? It's one of those key skills when you're dealing with an aggressive patient who's dangerous in your ward. Don't try and do what's right. Do what's going to make your patient feel safe in that moment. And if they're feeling safe and they're starting to calm down a bit, you want to use all your active listening skills. That means reflecting back to them to try and figure out what's the safety issue. Because quite often what people are going on about is those, those 9 mechanisms. So they're criticizing or they're analyzing or they're manipulating. You've got to try and figure out what is making them feel unsafe so I can perhaps help to address that. For those of you that want to learn, so usually a lot of us, when we get to that higher mode, we're able to naturally use the right language. For some people, that natural language is not always intuitive, especially if you're neurodiverse, for example. And there's some excellent methodologies that just teach you very simple techniques. Appreciative inquiry, I would really recommend that you can use to actually help communicate with somebody when they're in that very unsafe space and help them to feel safe and communicate. And I used to run clinics for teenagers in the UK where we talked about here to listen, not to talk. And that's your most powerful tool to restore relationships that might be going wrong. So a few final dragon trainer rules. You cannot arm wrestle a dragon. You cannot think yourself out of dragon mode. So with arm wrestling, I mean, you can't go dragon to dragon, keep your dragon out of the party. If you're on dragon mode, don't try and think yourself, oh, I have to now calm down. Find those physiological methods to get yourself to calm down. And remember, you've got that dragon master superpower, compassion, both for others, but also for yourself. And so remember, last few tips before we close this particular section: don't make important decisions or have significant conversations or post anything on social media when you're in dragon mode. And I think a lot of people's lives would be a lot happier and a lot less complicated if they did not post stuff when they're on social media. So if you're having to have a really important conversation with your child or your mother or your partner, or have to have a conversation with somebody at work, make sure that you are in that higher level balcony view before you have that conversation. So that brings into conclusion this particular section. I did warn you guys I was going to go over. So for those of you that are willing to hang on, there's some good stuff coming up. If you have to go, that's fine. I'm going to record all of this. So I'll just do a punt here for those of you that might not make the next 20 minutes, is that there is some links that